everyone. A very good day to all of you. I'm Dr. Swati, one of the mentors in StudyMEDIC. So here we are yet again with another module, that is postpartum. So here in this discussion, we will discuss 10 SBAs and 10 EMQs of the most recent exam tested questions related to postpartum module. So let's start with the quote. Strive not to be a success, but rather to be of value. Divert all your energy towards positive things, in becoming positive people, in improving yourselves, and to become better and better people day by day. So let's first start with the SBAs. Coming to question number 1, Mrs. Priya Kapoor, a 28-year-old, is attending her antenatal class, where third stage management is being discussed. The midwife explains the differences between active and physiological management of the third stage, including the associated risks. Now she asks about the approximate incidence of PPH more than 1 liter with physiological management. So what's the approximate incidence of PPH with physiological management of third stage of labor? So here, if we look at the percentage described in the NICE guideline, it's approximately 29 in 1,000. The incidence of bleeding more than 1 liter with physiological management of third stage of labor. So if we convert 29 into 1,000 into percentage, it will be approximately 2.9%. So the closest number to that is approximately 5%. So the correct answer becomes C. So the incidence of PPH exceeding 1 liter during the third stage of labor is approximately 5%. Actually, it's 3%. If 3% not in options, 5% is close. So we can put 5% with physiological management. It involves allowing the placenta to deliver naturally without intervention, which increases the risk of PPH compared to active management. So while it avoids some risks associated with active management like medication-related side effects, but the risk of significant bleeding stays higher. So why other answers are incorrect? Because they are quite far from the correct answer. 0.1 and 0.5, as we can see, are quite low, and 10 and 20% are overestimating the risk. So 29 in 1,000, that is 2.9% is the actual incidence. Whereas in active management, it reduces significantly the risk of PPH, the actual risk being just 1.3%. So we can remember like 30 in 1,000 and 13 in 1,000. So women should be informed antenatally about the risks and benefits of both. In antenatal classes, they usually tell about the risks and benefits of both physiological and active management of third stage of labor. And explaining all the pros and cons, the woman is allowed to take decision by herself whether she wants to opt for active management or not. Coming to the next question, Ms. Sarah Green, a 27-year-old woman, develops PPH approximately 1 hour after vaginal delivery. On examination, the uterus is well contracted and there is no evidence of retained products of conception. The midwife estimates the blood loss to be around 700 ml. So what's the most appropriate next step in management? Now we all know that atony is the most common cause of PPH. So tone and tissue is already ruled out. So now what next? We should look for or be aware of tone is ruled out, tissue is ruled out. So next comes trauma. So to exclude trauma, we need to examine her very well in an illuminated light, under illuminated light. So before starting all these, PRBC will only be started if she bleeds a lot and starts getting hemodynamically unstable, or depending on other clinical circumstances. Oxytocin uterine massage would not be of any role because uterus is already well contracted. Tranexamic acid, yes, you can consider, but your first and foremost action will be to examine her so that you can explore the cause. What is the cause of bleeding? Because even if we administer tranexamic acid and don't examine her and there is a tear, she will keep on bleeding. So first and foremost, most appropriate next step will be local examination. When the uterus is well contracted and PPH is ongoing, the most likely causes trauma to the genital tract. So to rule out any tear or laceration, it's essential that we examine her in well-illuminated light to look for any hematoma or any other source of bleeding. Okay. So if we look at other answers, start 1 unit PRBC, yes, IV fluids and blood are important for resuscitation, but do not address the underlying cause. So they are not the most appropriate next step. Here, identifying the source of bleeding or the cause of bleeding takes priority over this. Oxytocin and uterine massage, as we can see, they both are directed towards management of uterine atony, which is not the case here. Tranexamic acid may reduce bleeding by stabilizing clots, but should not precede identification of the bleeding source. This will go on simultaneously, but the most appropriate next step would be examination. Okay, so we should be well aware of the 4 T's. If well-contracted uterus, tissue is, that is retained tissue is excluded, then trauma should be suspected. And for that, a careful local examination is critical. Next, coming to question number 3, Mrs. Laura Brown, a 29-year-old, presents 10 days postpartum with a history of significant PPH. Now this becomes secondary PPH. She was readmitted 5 days ago and treated for secondary endometritis with intravenous antibiotics. Okay, so she was admitted 5 days ago for secondary endometritis. So she is now discharged, breastfeeding well, and reports mild fatigue. Blood tests reveal hemoglobin of 9.5. She is hemodynamically stable and her infection has resolved. So what's the best management for her anemia in this scenario? All right. So her hemoglobin is right now 9.5. So best management for her anemia in this scenario, if her bleeding is stable and antibiotics have acted well, then she doesn't need any more antibiotics now. Blood transfusion will only be needed if her hemoglobin is still low. So now iron supplements can be tick marked as the correct answer. So the correct answer is D, iron supplements. They are the most appropriate treatment for a stable postpartum woman with mild to moderate anemia, especially when she is feeding well and not actively bleeding. If anywhere it is mentioned that she is having significant ongoing bleeding, she has had history of significant PPH 5 days back. If 5 days back she had PPH, she was already treated with intravenous antibiotics. Now her hemoglobin is 9.5. There is no significant ongoing bleeding. So now oral iron are sufficient enough. Oral iron is sufficient enough to replenish the iron stores and to support the hemoglobin recovery. So blood transfusion, we can say, is unnecessary in this case because this anemia is not severe and the patient is not very symptomatic except for mild fatigue. Right now, there is no active infection. The endometritis has resolved with prior IV antibiotics. No additional signs of ongoing infection. Hence, additional IV antibiotics are not necessary right now. Transfusion is typically reserved for symptomatic anemia or hemoglobin below 7 in stable patients. Diet, if we look, while a nutritious diet aids recovery, but it is not in itself sufficient enough to correct the postpartum anemia caused by iron deficiency. So since postpartum hemoglobin, we expect it to be above 10. If it is not, then we resort to oral iron first. So mild to moderate anemia, especially between 8 to 10 in stable postpartum women, is best treated with oral iron. Transfusion for severe anemia less than 7. Now, Miss Rebecca Clark, a 30-year-old woman with epilepsy, is on lamotrigine monotherapy. She delivered a healthy baby boy 2 weeks ago and has been breastfeeding. During her postnatal follow-up, she mentions experiencing mild auras which she had not reported during pregnancy. What's the most appropriate adjustment to her lamotrigine dosage? Now, here it's a little bit dicey whether to increase lamotrigine dose or to reduce the dose. So, and if suppose we have got an option like adjust the dose based on lamotrigine plasma levels, then that's the best option. So adjust the dose based on lamotrigine plasma levels is the best option because even in TOG, which is related to anti-epileptic drugs. There it is written that not every anti-epileptic drug, but drugs like lamotrigine, they require monitoring of plasma levels postnatally to allow adjustment to dose. Okay, so the best answer here is adjust the dose based on lamotrigine plasma levels. Postnatal adjustments should be guided by plasma drug levels rather than fixed assumptions. During pregnancy, what happens? Lamotrigine metabolism is accelerated, means it is cleared out more, cleared out fast due to increased hepatic glucuronidation. So its levels become low. So we increase the dose generally during pregnancy. Postnatally, enzyme activity decreases. Hence, now it will be there in plasma, potentially causing lamotrigine levels to rise, necessitating careful monitoring and dose adjustment. So if plasma levels are found to be subtherapeutic, like here, for example, mild auras are there, that means somewhere the levels may be subtherapeutic. So dose increase may be warranted to prevent seizures. So partially, if we look at other options, increase the dose postnatally may be partially correct, but assumes low plasma levels without measurement. If adjustment should be individualized based on drug levels and clinical symptoms. Reduction in dose, while enzyme activity decreases postnatally, a blanket dose reduction risks seizures if drug levels are already low. It might seem that, yes, in pregnancy, the drug was fastly cleared. Now, hepatic glucuronidation has slowed down, so drug levels are staying in the body. So we should reduce the dose. So if we go by that mechanism, then we should reduce the dose. But we can't reduce the dose without measurement of the plasma drug levels. Maintain the same dose is unlikely to be appropriate, as changes in metabolism post-delivery often necessitate dose adjustments. Switching drugs, why do we switch? If it would have been ineffective or poorly tolerated, then the consideration of switching would be there, but not right now. So the best option is to adjust the levels, adjust the lamotrigine dose according to the plasma levels. 30-year-old woman undergoes a forceps-assisted vaginal delivery due to prolonged second-stage labor. To reduce the risk of post-delivery infection, which prophylactic antibiotic is recommended? So now, for assisted vaginal birth and instrumental deliveries, we recommend amoxicillin and clavulanic acid combination according to GTG as well as NICE. So this is the recommended prophylactic antibiotic. This combination provides broad spectrum coverage, targeting gram-positive, gram-negative, as well as anaerobic bacteria, commonly associated with postpartum infections. Clavulanic acid does what? It's a beta-lactamase inhibitor and enhances the effectiveness of amoxicillin against the beta-lactamase-producing organisms. So a single IV dose of amoxiclav is administered immediately after the procedure to reduce the risk of endometritis, perineal wound infections, as well as sepsis. Amoxicillin alone won't be the correct option because it would lack anaerobic coverage, making it less effective. Cephalexin may be used for oral follow-up, but is not suitable for initial prophylaxis in this setting. Clindamycin is reserved for patients with beta-lactam allergies and doesn't provide the same broad spectrum coverage as amoxiclav. And metronidazole, it primarily targets anaerobes, so it would need to be combined with another agent to provide complete coverage. So here amoxiclav is the best option as prophylaxis for assisted vaginal delivery. In a 100 kg pregnant female, how much is 40% blood loss or life-threatening blood loss from PPH? Now, in a pregnant lady, the total blood volume is 100 ml per kg. So in 100 kg woman, it would be 100 into 100. That is 10,000 ml would be the total blood volume. So 40% of 10,000, whatever it would be the answer. So 40% of 10,000 would be 4,000 ml. So 40% blood loss from PPH is 4,000 ml. Total blood volume per body weight is 100 ml per kg. Blood volume is 10,000. 40% of 10,000 is 4,000 ml. have a look at this table. This table is from quantification of obstetric hemorrhage in the recent TOG. So here 40% blood volume loss is life-threatening hemorrhage. 100 kg lady, it's 4000 ml, okay? No need to remember as such by heart, but you should just know 100 ml per kg is the total blood volume. 15% blood volume loss is moderate hemorrhage, 30% blood volume loss is severe hemorrhage, and life-threatening hemorrhage is 40% blood volume loss. Now, as a part of my specialty subject requirements, I was posted in Corporation Maternity Hospital. When I was posted in antenatal ward, I have taken Mrs. Vasa for antenatal assessment. She was diagnosed with anemia. She was very cooperative, took medicines and improved her hemoglobin. She has delivered yesterday. She wants to know how much is the hemoglobin level to be in the postpartum period. So here we should know the thresholds. 11, 10.5, 10. This is the general sequence. So postpartum, it's 10. It should be maintained above 10. At first visit, usually it should be 11. At 28 weeks onwards, it should be more than 10.5. And postpartum, it is expected to be more than 10. So remember these thresholds. These are from British Committee for Standards in Hematology as well as GTG. A 25-year-old who is 40 weeks pregnant in her first pregnancy is in the second stage of labor. She has been actively pushing. CTG shows a baseline of 150, normal baseline variability, occasional accelerations, and infrequent typical variable decelerations. She is contracting 3 to 4 every 10 minutes. Vaginal examination reveals a fully dilated cervix with fetal head in right occipito-anterior and station +3. Soon she delivers after right mediolateral episiotomy. She has delivered. So now what antibiotics are given after this episiotomy to patient? So does episiotomy routine requires antibiotics? Episiotomy routinely requires antibiotics or not? It doesn't. So the correct option is no antibiotic required. Unless and until it's an instrumental delivery, antibiotics are not routinely required for episiotomy. What's the mechanism of action of tranexamic acid? The mechanism of action of tranexamic acid is plasminogen activation inhibition. So it inhibits the plasminogen activation. It's a plasminogen activator inhibitor. It inhibits the dissolution of thrombosis and fibrin that leads to menstrual flow. It can reduce flow by up to 50%. Mefenamic acid works by inhibiting prostaglandin synthesis. It reduces menstrual blood loss by around 25%. These two percentages are also important. They have also been asked previously. Tranexamic acid reduces flow by up to approximately 50%. And mefenamic acid reduces menstrual blood loss by around 25%. Activation of antithrombin 3 and inactivation of factor 10A, they are the primary mechanism of action of heparin. The last SPA, when to start OCP in postpartum breastfeeding women. Now, postpartum breastfeeding women, it should be started between 6 weeks to 6 months. All women should undergo a risk assessment for VTE also postnatally, and CHC should not be used by women who have risk factors for VTE within 6 weeks of childbirth. So if risk factors are there within 6 weeks, it should definitely not be started. This applies to both, whether they are breastfeeding or not. So within 6 weeks, OCPs are never to be started. Women who are not breastfeeding and are without additional risk factors for VTE should wait until 21 days after childbirth before initiating any CHC method. So better have a look at this flow chart. For postpartum breastfeeding, if we look at CHC, so UK-MEC1, it becomes after 6 months. Okay, so after 6 months, it becomes UK-MEC1. But between 6 weeks to 6 months, you can start. It is UK-MEC2, that is benefits outweigh risks. So you can start after 6 weeks in breastfeeding women, but ideally UK-MEC1 is only after 6 months. Now let's come to the EMQs part. Mrs. Y is 30 years old, multiparous Asian woman who has had one previous C-section. She has a spontaneous vaginal delivery. Soon after delivery of the placenta, she was given prophylaxis. Bleeding was well controlled. Now, 4 hours after delivery, she seems to be bleeding heavily. Midwife calls you for help. Initial measures have been tried. What's the most appropriate next pharmacological action? Now, these are the options. 4 hours after delivery, she is bleeding heavily. So help has already been called. Initial measures have already been tried. Next pharmacological action, somewhere we have to choose for the oxytocin. Misoprostol is given, but if prior to misoprostol, if we get option like oxytocin, then that would be more preferable. So 40 units of oxytocin in IV drip would be our next pharmacological action. So rub up the uterine fundus, empty bladder. It is written that initial measures have already been done. Oxytocin 5 units, slow IV, if it would have been in the option, this would be correct. Ergometrine, if it were in the option, that might be correct if there are no contraindications. And oxytocin infusion comes next. So oxytocin infusion is there in the option, so you will go with that. Please remember the sequence very, very well. Look at the hemodynamic status of the patient. Look at any contraindications for any drug. If she's asthmatic, you can't give carboprost. If she is cardiac patient or hypertensive PIH, you can't give ergometrine. And if she is hypertensive, the rate of oxytocin infusion should be slow. So please be aware of all these clinical circumstances and then only choose the correct option. Okay. A 32-year-old in her second pregnancy has had a vacuum delivery for failure to progress. Then she has had a massive PPH of 3 liters. Help has been summoned and IV access obtained. On examination, the uterus is well contracted and examination of placenta seems it's complete. Well contracted means atony is ruled out. Examination of placenta seems it's complete means retained tissue is chances are also very less. So now again, similar to the SBA, you have to be on the lookout for trauma. Okay, tissue and tone are okay. So for ruling out trauma, you need to examine her under anesthesia. So we will look for this option, and if it is there, we will go for it. Also, sometimes if pharmacological measures fail, surgical interventions should be initiated sooner than later. So patient is taken to OT. If it is also given in GTG, like if after 3 doses of carboprost, she's not improving, her PPH is not improving, it's better to take her to OT for examination under anesthesia and initiating other surgical measures. So beware of these causes, 4 Ts. Next, a 25-year-old Asian woman, 14 days postpartum, is transferred by her community midwife due to a history of a foul-smelling vaginal discharge and excessive bleeding for the past 24 hours. On examination, her BP is 120/60, pulse 110, temperature 38.5. This is a red sign. 14 days postpartum, temperature high. Uterus is tender on palpation. Again, both these things point towards endometritis, right? Which is the most common cause of secondary PPH. On PS, that is per speculum examination, there is mild to moderate vaginal bleeding, os is closed. What's the most appropriate management option? Now, temperature high, uterus tender, most common cause of secondary PPH we know is endometritis. So we will start looking for antibiotics as the first most appropriate management option. So we get here, so we will mark H. Pelvic ultrasound scan, some of you might think that why not pelvic ultrasound scan to look for retained tissue? That will stand second. They are commonly performed on women presenting with secondary PPH to identify any RPOC. But first thing what you will do, you will initiate broad spectrum antibiotics. Combination of Clinda and Genta is appropriate. And once uncomplicated endometritis has clinically improved with IV therapy, there is no additional benefit from further oral therapy. Now, this set of EMQs is based on breastfeeding. So patient with mental health problem, She delivered on lithium. She preferred to breastfeed her baby. Ideally, we don't recommend, but she preferred to breastfeed her baby. Now her baby develops floppy tone. What's your advice? So ideally, we should measure the drug level in baby. Because lithium passes easily into baby's circulation through breast milk, giving the baby a high level of lithium in their blood. Ideally, the NICE and British Association, they recommend not to breastfeed whilst taking lithium. But she chose to breastfeed. There have been some cases reported of women successfully breastfeeding when taking lithium. So if you do want to breastfeed, talk to your psychiatrist and obstetrician. Your baby will have to have regular blood tests to monitor his or her lithium level, thyroid, and kidney function. What about postpartum women taking nifedipine and breastfeeding? Nifedipine is actually a good drug which can be given postpartum in breastfeeding mothers. So she can continue breastfeeding or commence breastfeeding. No adverse effects have been reported. Even it is used to treat painful nipple vasospasm in nursing mothers who do not respond to hot compresses and avoidance of cold exposure. So nifedipine is safe to continue in breastfeeding. Okay. Now, next set of questions is based on headache. Let's have a look. A 23-year-old woman with a BMI of 45 is now 36 hours post-emergency cesarean section for failure to progress in labor. She is complaining of a frontal headache that developed over the last few hours. The headache is worse every time she stands up to care for her baby. Now, the question is providing us hints. First, she is post-cesarean section. Headache is frontal. Getting worsened on standing up. Neurological examination, fundoscopy are normal. So these three features point towards, yes, dural puncture headache. Puncture of the dura occurs in 0.5 to 2.5% of epidurals. If accidental dural puncture occurs with an epidural needle, there is a 70 to 80% chance of this headache happening. Region is usually fronto-occipital region, radiating to neck. Characteristic is that it worsens on standing, develops 24 to 48 hours post-puncture. What you will do? Give her hydration and simple analgesics. Even if untreated, it lasts for a week to 10 days. Sometimes it can last still longer, up to 6 weeks. Last resort is epidural blood patch. It has got very high cure rate. Okay. A 33-year-old woman with a BMI of 32 is 4 days post-normal vaginal delivery on the midwife-led unit. She complains of a pulsating left side headache that has developed over the last 30 minutes. She is nauseous and has vomited twice and is asking to lie still in a dark room. Nausea, lying in a dark room, pulsating single side headache. It points towards migraine, right? Observations are normal and neuro examination, fundoscopy are normal. So this is most probably a case of migraine. Because it is accompanied with nausea, she is getting relieved in a darkened room, and it is typical, pulsating and unilateral. So migraine is classically unilateral, pulsating, builds up over minutes to hours, moderate to severe in intensity, associated with nausea, vomiting, sensitivity to light or sound. It's disabling and aggravated by activity. Okay. So pregnancy, as such, can alter migraine aura and trigger attacks of aura without headache. Because there is a high concentration of estrogen in pregnancy. So sometimes aura presents for the first time in pregnancy itself. Now, this set of questions is regarding mental health. A 40-year-old woman is 4 weeks postnatal after her first pregnancy. She had a cesarean section and has no past medical or mental health history. She has not been sleeping, has been feeling very low and crying a lot. Baby has been readmitted due to excessive weight loss. That means it is of concern. Now, 4 weeks postnatal, time of onset points towards postnatal depression. Symptoms are also that of postnatal depression. Baby is not being taken care of well. That means it's not blues. It points towards postnatal depression. Severe postnatal depressive illness has an early onset in the first few weeks, but unlike puerperal psychosis, this tends to be gradual and does not clearly manifest until 4 to 6 weeks postpartum or later. Okay. Feelings will be that of morning wakening, diurnal variation of mood, slowing of mental function, crying a lot, not being able to take care of baby well. So day-to-day life and care of newborn both gets affected in postnatal depression. A 24-year-old woman has delivered her first baby by C-section. She is seen by the midwife 3 days postpartum with emotional instability, insomnia, and agitation. She seems to improve a little over following 72 hours, but continues to have similar symptoms intermittently over the next 6 weeks. Baby is well looked after, a big sign that she is baby blues. The time of onset is that of either baby blues or postpartum psychosis, but postpartum psychosis doesn't improve by itself. Just slight emotional instability, insomnia, and slight agitation won't be the characteristics of postpartum psychosis. There the symptoms are more severe. Baby obviously won't be well looked after in postpartum psychosis. So here the symptoms point towards baby blues. It's quite common, affects 50 to 80% of all new mothers, self-limiting, lasting for approximately 48 hours, but sometimes it can keep on recurring over the next 6 to 8 weeks, particularly when the mother stays tired. Now coming to the last EMQ, a 33-year-old woman is 3 days post-delivery and presents with anxiety. She appears very frightened and exhibits paranoid ideation that her family is trying to take her baby away. Means now delusions, hallucinations, paranoid, and time of onset is also that of puerperal psychosis. She has a history of schizophrenia but has been stable without treatment for 5 years. So now this is highly suggestive of puerperal psychosis. The risk is very high, especially if there is a personal history of mental health illness. She's not on treatment because she was doing well, but pregnancy and postpartum state might have aggravated the condition. So the best option here is puerperal psychosis. It's a psychotic illness arising in a previously well woman within a defined period after childbirth. Usually this also has a very early onset in the first week itself. The term covers those women who have a lifetime first onset psychotic illness following childbirth. Also, who have previously had a psychotic illness, but have been well in the years preceding their pregnancy or postpartum. So this chart would help you guys to differentiate between blues, depression, and psychosis. Blues peak is on day 5. Here, psychosis peak is also in the first 3 days. Symptoms and treatment. So like this, you can easily differentiate between blues, depression, and psychosis. So that was all. Hope it was helpful for you to cover up some questions, the recent exam tested questions of the postpartum module, especially of 2024 and 23. So thank you guys. Keep studying. All the very best.